Okay. So the thing that I want to start with is for most of Western societies and modernized cultures and stuff, not, but I want to say that with some caution. The main diagnostic tool that is used is what's known as the Diagnostic and Statistic Manual of Disorders from the American Psychiatric Association. And we're on the fifth edition. Um, and as you can see, it lists, right, we're going to divide these up a little bit into different types of disorders, but you can see that it just starts with the list and goes through each of the type of disorders that are listed within the DSM. Um, Now, I should state that this is the way this manual works, is if you remember when we went through and discussed how disorders can be defined. We said it's a cluster of abnormal behaviors. So the statistics part of it, there's two parts to the statistics, is one, identifying those clusters of behaviors, and then two, providing a statistical overview of the probability of diagnosis, the age range, which age range are more common than other age range. Sometimes it will talk about ethnicity, such as some of these disorders are more common among Black Americans versus European white Americans. I will say what is missing in this and those demographic issues is dealing a lot with Native American communities, as Native Americans are commonly clustered with European white in the statistics manual. So that's something that has kind of bugged me for, and I don't know why they haven't corrected those kind of numbers yet, but that is something to note given that we're a tribal college. Um, but the cluster analysis is basically what you do when you get a cluster analysis is you measure a whole bunch of things. And wherever things lay over each other, so you see these three things. Let's say this is sleep issues, this is motivation issues, this is eating issues. Where those cluster overlie, this is where we get those clusters of behaviors. And we do this using statistical methodology, okay? And so when we get these overlaying symptoms, we go and then investigate. So what is unique about having those symptoms clustered together? Why is it those are clustered together? And then this is where it goes from the objective to kind of the subjective perspective on mental disorders, is basically it's put out to the members of the psychiatric association saying, here are some common symptoms. Have you seen them in your practice? What is the level of dysfunction? What is the level of impact it has on the person's life? And it's kind of done in a democratic method where it says, they say, well, I haven't seen this. I don't think it should belong in the DSM, and they kind of do a democratic vote. Okay. And this is where, again, this is again going back to the state of our clinical psychology eras, our mental health issues. Okay. Is if, let's say in the medical field, you get people who have, uh, 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 let's say, breast cancer. Okay. Um, the American Medical Association probably wouldn't put out a vote to their members on whether breast cancer exists or not. It's either a cancer or it's not a cancer. Okay, there's no debate about it. Okay, but in our current state of mental health and determining mental illnesses, there is this subjective part to it, where it is very much not an objective, yes, this disorder exists or not. It's more of a majority vote. Okay. And probably one of the better examples of this is homosexuality. Okay. Homosexuality has only been considered not a disorder for about 30 years here in the United States, because it was between the DSM-3 and DSM-4 that homosexuality or being gay was taken out of the DSM. Okay, and that happened in the 80s and 90s. Okay, um, and so it's only been about 30 years that if you were a gay man, that you weren't considered to have a disorder, or a lesbian woman, you weren't considered to be sick or disordered or have an illness. All right. And the reason why it was taken out of the DSM wasn't because of the objective evidence that being gay or being lesbian or homosexual is not a choice, or that it's more likened to being a cisgender or whatnot. It wasn't based on evidence. It was based on a vote of the American Psychiatric Association. So each individual psychiatrist basically put in their vote whether they think it should be a disorder or not. And just to let you know, not all psychiatrists voted for it not to be a disorder. Okay. Um, and so that's an example of the subjectivity of a lot of these things. Okay. But it does have some value, and it does help us guide treatment modalities between stress disorders and whatnot, which I'll get to here in just a minute. Um, uh, the other thing that the DSM-5 does that is different from previous versions of this manual is it puts most all of these disorders on a spectrum. Okay. And so you will hear things like the autism spectrum, the ADHD spectrum. Okay. Basically, what the spectrum is from mild symptomology to severe symptomology. And what it does is sets up a level of care dependent upon the severity of the symptoms. Okay. Which we'll get an example of when we look at autism and autism spectrum. Okay. So that's the other kind of thing that the DSM-5 does for us as well. Okay, so let's take a look though. Let's simplify the DSM, because it really puts the disorders into basically four categories. Okay, the first one is developmental disorders. These are disorders that are usually diagnosed in early childhood. Some common, probably the most common ones that we hear about are ADHD, or attention deficit hyperactivity disorder, and autism spectrum disorder. But this can also include intellectual disorders, language delay disorders, physical delay disorders, all of those types of developmental disorders as well. Okay. The second two are, one is mood, meaning low affect or manic phase, or stress, meaning anxiety type disorders. Okay. Mood disorders, probably the most common, again, are major depressive disorder. And bipolar disorder is, and there's two types, which we'll get to, but it's basically where a person fluctuates between manic stages and severe depressive stages. That's what's called bipolar 1. Okay. Um, and then stress related disorders, probably the most common ones are anxiety disorders and post traumatic stress disorder. Okay. Which we kind of talked about PTSD a little bit earlier, but maybe we'll get into it a little bit more on Monday. Okay. So these are the ones that we want to cover this coming Monday. These are the ones that we're going to try and cover today. And then we're going to try and finish up with psychotic disorders on Tuesday. Now, the most basic definition of a psychotic disorder is when a person has a break from reality. So the two common ones are schizophrenia, where a person has delusions or they have hallucinations that don't actually exist within the objective reality world. Okay. And then there's a personality disorder known as borderline personality disorder, where a person has an unreal image of themselves between being being a decent person and they thinking that they're the most miserable individual in the world and they're not worth anything. Okay, but there's some nuances to this one that we'll talk about as we get to it. Okay. All right. So first of all, let's talk about autism. Um, and the first thing that I want to clear up with autism is there's a difference between the symptomology we see. So, symptomology being stemming behavior, the need for consistency, and those kinds of things, and what's driving that disorder. Okay. Autism spectrum disorder is unique because it's a social disorder. Okay, meaning that it is the inability to form and develop normal social relationships. And because of that, that causes such stress in the individual, it then they then retreat to a behavior that deals with that inability or that want to avoid social interaction. Okay. Many of you have probably noted in the news that there has been a huge increase in the diagnosis of autism, and people have tried to attribute this to the modern lifestyle, modern way of parenting, and probably the biggest bogus claim is vaccines, which is just a bunch of crap. But I kind of want to explain, really, kind of, at least from a scientific perspective, why we have seen such a large increase in the rates of autism. Because it goes back when we went from the DSM 3, 4 to 5. In that period of time, we have refined the definition of autism. We have refined the way it's diagnosed. Okay. So before the 1990s, there was such unclear guidelines on how to diagnose autism. Most children pre 1990s that had autistic symptomology were diagnosed with child onset schizophrenia or child onset psychosis. So before the 90s, before we refined it, most children who had autistic symptoms were diagnosed with some other, usually psychotic type disorder. Okay. And then progressing in the 90s, we then used what's called the spectrum, where we had mild to severe symptomology. And this widened the range of the number of children that could be diagnosed with autism. Indeed, in 2012, there was a mild version of autism known as Asperger's disorder, which uh, which was eliminated from the diagnostic criteria and put into the autism spectrum disorder. So if you look at around between 2010 to 2015, the number of individuals with autism skyrocketed. And that is because if a child was diagnosed with Asperger's, they had to go be re-diagnosed with autism in order to continue their care. Okay. So and then you have the public awareness part of it. Okay. We now have autism awareness days. I think there's actually a month that I think deals with autism. There's all kinds of stuff on the internet and everything else. So now there's that public awareness component to autism. Okay. And that probably most likely explains or increase in diagnostic rates of autism. Now, should it be alarming to us that there is this significant population of children who have autism? Absolutely. Is it something that is new or is coming to light? Probably not. It's probably always been here. It's just that the diagnostic criteria were not clear enough and not broad enough to capture the number of children who actually have autism. So I just wanted to provide that clarification because there's a lot of weird theories about why autism diagnoses have increased over the last several decades. Okay. So I do want to play this quick video, but I do need to stop sharing because I just realized I didn't do the sound. So let me turn the sound on. All right. That just kind of goes over a little bit more closely what autism is as a disorder. So
Hey there! Welcome to Life Noggin. A lot of people talk about autism, but not everyone understands what it is. Autism spectrum disorder, or ASD, affects how people communicate with and relate to others. This isn't the same as being shy or not knowing what to say. Most people with autism don't understand some of the basic social conventions that others take for granted. They might have trouble making eye contact, holding a conversation, or recognizing gestures. And over 1/3 of people with ASD are nonverbal, meaning they don't use speech. Along with communication issues, people with autism often like to follow certain patterns or repeated behaviors. Many have a sensitivity to bright light or loud noises, and others have physical problems like trouble walking or picking up small objects. Some have intellectual disabilities, but about half have average or above average IQs. It's also common for people with autism to have a great long-term memory for certain details, and many excel in math, science, music, or art. With such a wide variety of symptoms, no two people with ASD are alike. The behaviors vary so much that they used to be classified as different disorders. One was Asperger's syndrome, where people obsess over particular topics, miss nonverbal social cues, and may not understand appropriate social behavior. In 2013, scientists realized that the boundary between Asperger's syndrome and some of the other disorders was fuzzy, so they decided to put them all under one name. This made it easier to diagnose autism, which is important. The younger someone is diagnosed, the earlier they can get help. In fact, many children who have autism will show signs by just 2 years old, including not responding to their name, avoiding eye contact, and flapping their hands or rocking repeatedly. Even though there is no cure for ASD, therapy and medication can help people adjust. Scientists are also doing clinical trials to find other solutions. They've learned that 1 out of every 68 children in the US has the disorder, but they still aren't sure what causes it. Autism is over 4 times more common in boys than girls, and most scientists think genes play a role because it often runs in families. Some people with ASD have abnormal chromosomes, but this can't be the whole story. There are people with the same gene changes who don't have autism. Other possible causes include having older parents, being exposed to high levels of testosterone in the womb, and having complications during pregnancy or birth. It may even have something to do with gut bacteria, since many autistic people have gastrointestinal issues. But most likely it's a combination of many factors. The one thing scientists know for sure is that vaccines do not cause autism. No matter why it happens, ASD is being diagnosed at a higher rate every year. This doesn't mean it's becoming more common. It just means more people are aware of the condition and getting diagnosed early. And awareness is crucial. The more we learn about autism, the more we can understand and relate to those who have it. It's important to note that people with ASD deserve the same respect, fairness, and chances that people without ASD receive. This will help people with ASD adapt and grow in our communities. We've put some resources in the description if you would like to learn more about ASD and figure out what you can do to help. Is there another disorder or any other topic you would like us to talk about? Hey there!
All right, so that's a little bit clearer description of what autism is. And again, I want to focus on that communication aspect, okay? And so this is kind of what, if we were to look at it from a diagnostic perspective, some of the things that we would look for, okay? So when we look at autism, again, it's a deficit in social communication and social interaction. And this is an important part, is it's across multiple contexts, okay? So, and I'm going to bring this up when we get to ADHD, depressive disorders and whatnot, okay? Is when a person only has symptomology at one place, okay? But they don't have it in multiple contexts, then it's something to do with that situation. It has nothing to do with that child or that adult. Okay. So, for example, when we see autism, and let's say the child acts very autistic at school, but not at church, not at home, not at grandma and grandpa's house, then there's something wrong with the school setting, not with the child. And that's something to kind of keep in mind, especially when people come up to you and you know your child the best and they say, I think your child has a disorder. Question that if those symptoms don't exist except within that situation. So, and again, I'm going to bring this up in multiple places as well with other disorders, but this is an important one. As manifested by following current by history, again, so it's current and history. So the first one is deficit in social emotional reciprocity. So the inability to, when someone tells you something happy or sad, to express back in more of a empathetic or social way their feelings or how that makes them feel. Okay. Deficits in nonverbal communication, not being able to express oneself nonverbally. Okay. Deficit in developing and maintaining and understanding relationships. So the inability to play with another child appropriately, for example, and understand that social interaction, or maintaining some type of friendship. Okay. Okay. And then, so these are the three main ones. So this is what sets up autism. Okay. Now, this is those then resulting patterns of behaviors that we commonly see among autistic children. So some have stereotyped or repetitive motor behaviors. Okay. So this is kind of a needing to line up toys in a certain way, in a certain direction, insistence on sameness, not being able to break a routine in a daily interaction, uh, a fixed interest or an abnormal intense focus on a single thing or a preoccupation with a single topic. Um, and then a hyper or hypoactive sensory input or unusual interest in sensory aspects of the environment. Okay. So maybe it's an indifference to things like pain or temperature, or an adverse response to a specific type of sound or texture. And when we say adverse response, we're not talking about a child who tastes something and they don't like the texture of the food and they spit it out. We're talking about, in this case, a child exaggerating that expression to where they can't get it out of their head that they just interacted with that texture. Okay. They have what often is called as a complete meltdown because of that interaction with that specific stimuli. Okay. All right. And then some of the other criteria, of course, is symptoms must be present in early development. Um, Symptoms cause clinical or significant impairment in social, occupational. Okay, this is that part of diagnosis that we talked about. These disturbances are not better explained by intellectual disabilities, okay, or global developmental delay, okay. Intellectual disabilities and the autism spectrum frequently co-occur with each other to make comorbidity diagnosis. Okay, so in this one, sometimes it's because the child is intellectually has intellectual problems where they're just not to the same level that their peers are. This then can create these autistic types of behaviors and avoidance of social interaction that is common among autistic children. So one of the things that is often ruled out before diagnosing a child with autism is making sure they're not intellectually delayed or developmentally delayed. Okay. And it is common for these two to also co-occur, as it was noted in the video. While greater than 50% of children don't have an intellectual disability, they actually have an average or above average IQ. There is a certain percentage of children who have a deficit in IQ or intellectual abilities for their age. So those are all things that need to be considered before giving the complete diagnosis of autism or giving a co-occurring type of diagnosis. Okay. Now, this is the example of what was meant by it's a spectrum disorder. Okay. And so if you look at these different levels, we go from requiring some support to requiring complete and substantial support. So this goes from doing some weekly interactive training with a child, making sure that their world is more consistent, to actually having to be with the child or having some intervention almost 24/7. And that's just kind of the different levels that set the level of care for a child. Okay. Now, these spectrums are important, and this is one of the things that I'm kind of glad that the DSM-5 has done. Okay, because the temptation is a child with mild autism. The temptation can be throw every service that you can do at that child because that's only going to help them in being able to become independent and be able to function within society. But what we have found is that the treatment level needs to match the level of disorder that the person has in order to be successful. Okay. Probably a good example of this is I did research on peer support um, systems and whether peer support systems work or not. Okay. And in these peer support systems, obviously the individuals who are receiving the peer support are also receiving the usually a lot of services. Okay. And what we found is that for people who have severe mental health disorders, peer support programs work wonderfully. They actually help the individual and whatnot. For people with moderate mental health, it does nothing for them. They stay at the same symptomology and everything else. Individuals with mild symptomology, so this would be the level 1 in the example of autism, it actually makes their mental health condition worse. It makes them have more severe symptomology in a peer support program. Okay, so this is an example of kind of some of the reasons we went to a spectrum system with the DSM, because the level of intervention really needs to match the level of disorder or of severity of symptoms that we see within an individual. Giving a child who has mild symptomology the whole world can potentially take them from a level 1 autistic child up to a level 3 autistic child. And that's not what we really want to see. So that's kind of the idea behind the spectrum, um, and how it's kind of used to determine what level a child has of autism, and then tailor the treatment modality that is going to be used for that child. Okay. So I do want to go, so causes, we always want to know, they went over some of the potential physical ones, such as the gut stuff, potential older parents, um, um, what were the other ones? Testosterone exposure, all of those are all being investigated as the potentials of physical reasons why. What I want to go over is the two leading theories on the psychological level. So, what are psychologists really looking at as far as determining what a child is, why a child has those autistic and those social symptoms? Okay, we've already talked about one earlier in the class, which is the broken mirror hypothesis. If you remember, this has to deal with theory of mind, the ability to uh, mirror neuron with other individuals, meaning that, again, just as a real quick recap, it's when you are really paying attention to someone's behaviors, the neurons that are firing in their head fire in your head, which then you use that to develop why they're behaving the way they're behaving. Okay. And so we've tested children with the theory of mind tasks and everything. And we have found that a good majority of these children do actually fail theory of mind tasks. The problem, though, just like with some of the biological explanations, such as the chromosome issue, is that not all children fail theory of mind tasks, just like not that non-autistic children can have those chromosomes that are suspect in autism. Okay, so for a hypothesis then to become a theory would need to explain all children with autism, but this only explains about 3/4, about 75% of children tend to have weakened theory of mind or no theory of mind abilities. Okay. The one that seems to be the one that is ahead of the investigations and probably has some both neurological evidence and some other growing evidence is what's called the overwhelming world hypothesis. Okay. Um, if you go through when we went through the sensations and perceptions section, we mentioned that we all have filters. We filter out information that we're not necessarily paying attention to. So, for example, I mentioned how a lot of long haul truckers that drive for years and years and years tend to have hearing problems. And the reason is on the road, technically, the noise on the road and everything actually produces decibels that can damage the ear. But I don't think any of us really realize that there's all this noise from the road coming in because we tend to be busy driving. We're focusing and attending on driving, so we don't realize that there's that other stimuli that is coming in and impacting us. Okay. And one of the theories of autism is that children with autism do not have those filters, that that all of the stimuli in the environment is coming at them, and they don't have the ability to not experience them. Okay. And I was talking to years ago, this was years ago, a developmental psychologist who was trying to explain this to me. And he's like, if you can imagine what we think the world of especially someone with severe autism is going through, is if you were sitting in the middle of a room and lights were flashing everywhere. And let's say in one corner of the room, rock and roll is blasting at you. In another corner of the room, country music is blasting out of you. Another one, rap, and then let's say the other one, classical music. And all of these stimuli are coming at you, and you have no ability to control them. You have no ability to censor them out. Um, and so this is the world they exist in. And then you add social interaction on top of that. That becomes way too much for the child to deal with. And so it's a social disorder because the child is dealing with such overstimulation that they can't filter out. Okay. And recently, there's been some neurological studies that have shown that indeed, the areas where we think we filter out information within the brain are bypassed in many autistic children. So this one is the one that is kind of gaining the most traction, that it's an overstimulation, that the world is just so overwhelming to these children that they then resort to fixed behaviors, stemming behaviors, those types of things in order to deal with this overwhelming world that they live in. Okay. So this one is the one that is kind of from at least psychological perspective of what a child is experiencing with autism. This one tends to be the one that a lot of developmental psychologists are really aiming, looking more into. So, but this is kind of the current state of, from a psychological perspective, what causes the symptomology we see with autism. And these are the two that have received the most attention. Okay. All right. Before we move on, I just want to put, you can put it in the chat um, or whatnot. Does anybody have any questions about autism? Thank you, Michael. Thank you, Teddy. All right, move on. So the second kind of childhood disorder that I wanted to kind of touch on in this class is ADHD. Okay, this is attention deficit hyperactive disorder. This is where a child has uh, difficulty attending to something for an extended period of time and has a hard time physiologically settling down. So they're constantly needing to be on the move. Okay, that's the basic definition for now. You probably have heard a lot about it being highly prevalent in the United States. And I kind of want to kind of give some uh, reasoning or maybe some ideas of why ADHD is highly diagnosed here in the United States versus other places. And this comes down to the model of diagnosis, according to a lot of the literature, is here in the United States, we use what's called a medical system of diagnosis, meaning that a person who has a set of symptomology is instantly diagnosed with ADHD. Okay, but and the most common place here in the United States that ADHD is diagnosed is in the school. Okay, so it's usually the observations of the teacher, and then it's sent on to The teacher identifies the child that can't pay attention, is always fidgeting in their chair, and sends them then to the specialist and all that kind of stuff. And it starts to roll. Okay. I should mention that most children who are diagnosed here in the United States were born in the month of August and September, which is kind of interesting. So is there something about being born in August and September that causes ADHD? While the current theory suggests not, if you look at most preschools and kindergarten, the cutoff period for entry into preschool or kindergarten are in the month of August or September. And so what this often causes is you have a mixture of older children with very young children. Okay. And what we find is that the majority of children who are diagnosed in the classroom are the youngest children in the classroom, which tended to be born in the month of August and September. Reason being, we think, is that the way a teacher determines whether a child might have ADHD or not is they compare that child's behavior to the behavior of the other children in the classroom. Well, what's a young child going to be doing? Not paying attention and being fidgetive compared to their peers. Okay. So I just kind of wanted to mention that because, again, it gets to the vagueness of our understanding of mental illness. Okay. Now, does that mean there's not valid cases of ADHD? And this is where I want to be very cautious. If we go back to our conversation with autism, if the child is ADHD in the classroom, at home, at church, at grandma and grandpa's, absolutely they probably do. Okay. But is there probably some cases where we might be overdiagnosing this based on a situational variable? Probably. Okay. And probably a good example of this is a comparison between the United States and France. Okay. Why am I comparing the United States and France? Is because our school systems are very similar to each other. Okay. And so you would expect, because our school systems are so similar, that because the majority of children who are diagnosed with ADHD are from schools, that prevalence rates should be about the same. Okay. But in the one study at the time, while it was a couple series of studies at the time, the diagnosis rate here in the United States was above 13%. Okay. But the diagnosis rate in France was below 1.5%. Okay. So how do we explain this disparity in diagnosis rates? Okay. Well, if we look at how France approaches ADHD versus the United States, again, here we use the medical model, that it's the individual that has the disorder. It's the individual that has the symptoms, right? And so it must be a disorder with the child, okay? That's not where France starts, okay? When they have a child in the school system that has ADHD, they actually go in and work with the family system first. They work with the parents, they work with the family, they make sure there's structure within the family, they make sure all of these things are in place before they'll give a diagnosis to the child. Okay. And what they have found, at least in their system of care, is that for a lot of children who have ADHD symptoms in the school place, that there's something that needs to happen in the classroom, and there's something that has to happen within the family system before we make it so that the child is the one that is going to be, quote unquote, diagnosed as that child has ADHD. Okay. So I bring this up because it's a different way of approaching a disorder between two countries, okay, that have similar education systems. All right. Another probably good example of some of the complications with different disorders is ADHD and Japan. Okay. Before the 1990s in Japan, you'd have a hard time finding any cases of ADHD. Okay. But what kind of happened in the 90s is before the 90s, Japan really wanted to, they very much emulated the American system and American universities. So starting in the 70s, especially, they started sending a lot of their youth to American universities, and then they would bring them back. Okay. And someone going to get their doctorate degree either in psychiatry or in psychology, in clinical psychology, the biggest topic in the 70s and 80s, especially dealing with children, was ADHD. Okay. And so this is where a lot of these doctors would do their dissertation on. This is what they would specialize on. And they would go back to Japan and put up their shingle saying, I specialize in this disorder with children. And they literally had no clients. No one showed up to their place of practice. Okay. Until the Japanese government got involved and started putting out these public notices. If you notice this in your child, if you notice this behavior, send them to our new specialists, our new American trained psychiatrists and psychologists. Okay. And in the 1990s, what we saw in Japan is we saw a 0% rate of ADHD, and it went up and it matched the United States rates of ADHD by the end of the 1990s. Okay. So this is another, again, a good kind of explanation. I'm going back to the example of autism and the increased amounts of autism we see here in the United States. I think ADHD and what happened in Japan is a good model to understand those increases in autism we see here in the United States, as we saw with ADHD in the 90s within Japan. Okay. So I wanted to bring these cultural nuances into the conversation so that we can kind of see them more clearly as far as different approaches to understanding how we should treat the child, to how sometimes these disorders can either be overlooked or seem non-existent until they're brought to the public light, until they're brought to attention. Okay. I think there's a video here. Oh, okay. All right.
What most people know, or think they know, about attention deficit disorder, or ADD, is that it's used to describe someone who can't stay focused, and when they really can't focus, they have attention deficit hyperactivity disorder, or ADHD. This continuum from one to the next isn't quite how it works, though. ADD and ADHD are actually synonymous, as in they're the same. ADD is an outdated term used prior to 1987, after which it evolved into ADHD to encompass more of the symptoms that people with ADHD often experience, which, in addition to being inattentive, includes both hyperactivity and impulsiveness. So somebody might be diagnosed with ADHD because they have symptoms related to not being able to pay attention, but they might also be diagnosed with ADHD if they have symptoms related to being overly active and impulsive. They might also have ADHD if they have symptoms of both. According to the Diagnostic and Statistical Manual for Mental Disorders, the 5th edition, the most recent update being in 2013, ADHD is split into 3 subtypes: inattentive, hyperactive impulsive, or both. Inattentive and hyperactive impulsive have a set of 9 symptoms each. For example, someone with the inattentive subtype might make careless mistakes, or not listen, or be easily distracted. And someone with a hyperactivity and impulsive subtype might fidget, or squirm around, or get up from their chair often. Now, you might be thinking that everyone fidgets now and then, right? Well, a diagnosis is given when someone has 6 of the 9 symptoms for either subtype for at least 6 months. Most commonly, though, children have symptoms of both subtypes, and therefore have the combined subtype. Since ADHD is considered a neurodevelopmental disorder, the symptoms also have to have started between age 6 and 12, and the behavior can't be appropriate for their age. Alright, but what causes someone to be hyperactive or impulsive or inattentive? Well, as you might guess, it's pretty complicated, and we don't really know. Probably a lot of different factors, and ultimately they all fall into some combination of environmental and genetic factors. One interesting clue to a genetic component of ADHD is looking at families. For example, a child with a sibling that's been diagnosed with ADHD is more likely to develop it themselves. Furthermore, if those siblings are identical twins, meaning they have the same DNA, their chances of developing ADHD is considerably higher. Having identical DNA doesn't mean that the twin is definitely going to develop ADHD though, which again suggests that both genetic factors and environmental factors play a part. As to a specific gene, it's probably not one single gene that leads to ADHD, but rather multiple genes that determines how severe their symptoms are. These genes likely influence the production or regulation of the brain's neurotransmitters, which are signaling molecules in the brain that are released by one neuron and received by receptors of another neuron. This movement of a neurotransmitter from neuron A to neuron B is basically a message being relayed. It's like the neurons are talking. Dopamine is a specific neurotransmitter that gets released when the brain's involved with behaviors like getting a reward, taking a risk, and being impulsive. Norepinephrine is another neurotransmitter involved in attention and arousal. It's thought that lower amounts of these two neurotransmitters floating around contributes to symptoms of ADHD. The reason why these neurotransmitters might be down in the first place is still not well understood, and research remains ongoing. Now, treatment for ADHD can be tricky, since symptoms might vary from patient to patient, although it most often involves either behavioral psychotherapy, medication, or both. Behavioral psychotherapy is often targeted at children and focuses on teaching the child better time management and organizational skills. For example, having structured routines that they can follow, and then giving rewards when they stick to those routines. Also, involving both parents and teachers are important, and both behavioral parent training and behavioral classroom management have been shown to be helpful for children with ADHD. For adults, behavioral psychotherapy might focus on ways of decreasing distractions and also improving organizational skills. If medications are prescribed, typically the first-line options are stimulants. Since it's thought that low levels of neurotransmitters are involved in ADHD, stimulants are used because they tend to increase the number of neurotransmitters, like dopamine, between neurons, therefore reducing symptoms. Common and well-known ADHD medications are molecules that are chemically similar to illicit stimulants like methamphetamine, but there are some key differences to keep in mind here. All of these chemicals help to increase the release of dopamine from neuron A, but the ADHD medications typically cause a slow release of dopamine, whereas illicit stimulants like methamphetamine cause a really fast release of dopamine. In fact, it's this incredible surge of dopamine that disrupts normal communication between neurons and produces euphoria, and is the reason that illicit substances like methamphetamine are highly addictive. In contrast, the slow and controlled release of dopamine caused by ADHD medications is key and helps a lot of patients improve their focus and their attention. Thanks for watching. You can help support us by donating on Patreon or
All right. I really like that video because it gives a kind of a good overview of the different criteria, one for diagnosis, but also some of the transmitter issues that we see common with ADHD um, and whatnot. I just lost my train of thought. Anyways, so just real quickly to go over ADHD as it was kind of presented in there is that again, there's categories for this. So the inattentive category, we have to have 6 or more of these criteria, and they must impact their social and academic or occupational activities. Again, that gets to the maladaptive part of being a disorder, okay? Some of the things that we do need to note is some of the rule out disorders that you have to rule out before you do ADHD, especially as a child is older, is you have to rule out oppositional behaviors and aggressive and hostile behaviors, especially for older adolescents, because it's very common for a child with oppositional defiant disorder to be diagnosed with ADHD. And what happens though is that they put them on the ADHD medication, and it actually increases their defiance, their aggression, and their hostility. So this is a very important note, especially when we're talking about diagnosing children in their adolescence or adult years, to rule those behaviors out as an explanation. Okay. So again, I'm not going to go over these. I'm going to go over these quickly. Fails to give close attention to details, make careless mistakes, difficulty sustaining attention, has a hard time listening when spoken directly to, often does not follow through with instructions, often difficulty organizing tasks, avoids, dislikes, reluctant to engage in tasks requiring sustained attention, often loses things, often easily distracted, is often forgetful in daily activities. And then, so you have to have 6 of all of those. And then again, as the video said, you have to have 6 of all of these. And again, going back to it, sorry, it needs to manifest at least 6 months. And again, I do want to bring this up, just like I did with autism, is these symptoms cannot just be displayed in one location, okay? So it can't be that these behaviors only occur at home, but not school, not your church, not grandma and grandpa's house, not the grocery store, okay? These have to be at least 6 months, and it has to be at multiple locations, all right? And so I just want to, again, bring that up, okay? So hyperactivity includes fidgeting, tapping hands, leaves seat often, runs about or climbs, unable to play or engage in leisure type activities, is often quote unquote on the go or driven by a motor, talks excessively, blurts out answers before the question is even completed, difficulty waiting turns, and interrupts or intrudes others often. Okay, so again, 6 out of all of these diagnostic criteria is kind of what they're looking for when they're doing this type of diagnosis. And then what we look for, especially when we're looking at adolescents and adults, is we then kind of do a historical thing to see if these symptoms existed before the age of 12. And again, this goes to the settings. It has to be in more than just one setting. So it has to exist within at least 2 of these, according to the diagnostic criteria. And again, it interferes and reduces the quality of the person's life, academics, and occupation. And the other thing is that the symptoms do not occur exclusively during course of schizophrenia or another psychotic disorder, and is not better explained by another disorder such as mood disorder, substance or intoxication, dissociative or personality disorders. So we really want to rule out some of these other ones, Reason being is when we deal with like mood disorders and anxiety, these are much easier to treat than others. And these, the dissociative disorders and personality disorders, are much harder to treat than ADHD. And so we'd rather be focusing on these than a misdiagnosed individual where we're giving them the inappropriate type of treatment for it. And then, of course, substance intoxication and withdrawal can cause attention deficit issues as well. So we want to make sure that it's not due to some type of substance use where someone has just stopped taking a drug or alcohol. A lot of withdrawal symptoms include the inability to attend to different things, the inability to be present, and it can also include some hyperactivity symptomology. So we want to be careful when we're dealing with someone who has a substance use disorder um, or is on substance as well. Okay. All right. All right, so where are we heading? So that to finish this up, I will ask if anyone has any questions here in just a minute about ADHD and autism. But where we'll start on Monday is mood disorders, dealing with the main one is we'll be dealing with depression because there's often some clarifications that need to be made with depression, and it's different from grief or sadness or loneliness. And we want to make sure that we make these differentiations before we go get someone on some type of medication or treatment for a mood disorder. So I'm going to stop my sharing.